The next topic is vasculitis. This is a clinico-pathologic process which involves inflammation and damage to blood vessels, leading to compromise in vessel lumen, which further leads to infarctions and ischemias. The clinical features of vasculitis depends upon the size of vessel involved, the location of the vessel that is involved. Most of the vasculitis occurs due to immunological mechanisms, and these can be either primary vasculitis, where the disease process is primarily due to a vascular pathology that is immune mediated, or it can be a secondary vasculitis where there is an underlying pathology and vasculitis is secondary to a primary condition. Some of the examples include SLE and drug induced. Let's look at some of the primary vasculitis syndromes. The first one among them is granulomatosis with polyangiitis, GPA in short. This is also known as Wegner's granulomatosis. This condition is classically characterized by lung and kidney involvement. The lung involvement is in the form of granulomatous vasculitis of upper and lower respiratory tracts. Kidney involvement is in the form of glomerulonephritis. The upper respiratory tract involvement can lead to purulent or bloody nasal discharge, recurrent sinusitis, mucosal ulcerations of the nasal mucosa. Patients can have septal perforations and a characteristic cartilage destruction of the nose, leading to a saddle nose deformity. Lung involvement, on the other hand, can be asymptomatic, or patients can present with cough. Patients can also have hemoptysis, and they can also present with dyspnea. Kidney involvement in the form of glomerulonephritis can be rapidly progressive disease, and it can lead to renal failure. A second disease among the primary vasculitis is microscopic polyangiitis. This is a small vessel vasculitis that affects the lungs and kidneys again. Here, even the medium-sized vessels can also be affected. A third subtype is eosinophilic granulomatosis with polyangiitis, also known as EGPA. This condition is commonly known as Churg-Strauss syndrome. This condition is characterized by granulomatous vasculitis of multiple organs. Most commonly involved organ is lungs. Clinical features include asthma or asthma-like symptoms. Patients can also have peripheral eosinophilia. Biopsies can show eosinophilic infiltration. Kidney involvement can lead to glomerulonephritis. The most common or most important cause of death in such patients is cardiac involvement. Next important vasculitis is giant cell arteritis, GCA in short. GCA is not in fact a single entity, it is a spectrum of disease including giant cell arteritis and polymyalgia rheumatica, presenting at different ages and presenting with different symptoms. Here medium and large vessels are involved. Most commonly involved are branches of carotid arteries. Classical symptoms include headache, jaw claudication, scalp tenderness, fever, and other constitutional symptoms. Patient can also have muscular pains. The muscular pains can be an early symptom of polymyalgia rheumatica. An important complication of GCA is sudden loss of vision if optic artery is involved. So identifying the disease and treating it early in its stages can lead to prevention of loss of blindness in such patients. The next important vasculitis is Takayasu arteritis. This also is a vasculitis of large arteries with particular predisposition towards the arch of aorta and its branches. This disease usually presents in young women with symptoms of ischemia in upper limbs, head and neck. Patients with aortic root involvement can present with aortic regurgitations. The next important vasculitis is IgA vasculitis, also known as Henoch-Schönlein purpura or HSP in short. This vasculitis is particularly more common in children and it can involve kidneys, GI tract and skin. The next important type is cryoglobulinic vasculitis. As the name suggests, it is associated with cryoglobulinemia, and as HCV is associated with cryoglobulinemia, most of these cases present in patients with chronic hepatitis C virus infection. In these cases, an aberrant immune response leads to formation of excessive levels of cryoglobulins. This condition is characterized by cutaneous vasculitis, arthritis, peripheral neuropathy, and patients can also have glomerulonephritis of kidney. The next subtype is idiopathic cutaneous vasculitis. Cutaneous vasculitis is broadly defined as inflammation of blood vessels belonging to dermis. In about 30% of the cases, this cutaneous vasculitis can be truly idiopathic, that is, there is no identifiable cause. But in 70% of the cases, there will be an underlying condition that can lead to cutaneous vasculitis. The other miscellaneous vasculitis syndromes include Kawasaki disease, primary central nervous system vasculitis, single organ vasculitis, Behçet's disease, Cogan's syndrome, polyangiitis overlap syndrome. Kawasaki disease is a rare childhood rash that is associated with vasculitis and fever. In such patients, heart is also affected. Primary CNS vasculitis involves the brain and spinal cord involvement, leading to recurrent headaches. Patients can also present with seizures. Single organ vasculitis is, as the name suggests, involvement of just single organ, such as skin or kidney or liver or lung. Behçet's disease is a chronic inflammatory vasculitis characterized by oral and genital ulcerations. Patients can also present with eye symptoms and also skin rashes. Cogan syndrome is an extremely rare autoimmune disease where there is involvement of eye in the form of interstitial keratitis, along with inner ear issues, where the patient can present with loss of hearing, that is, hearing loss, and vertigo. Polyangiitis overlap syndrome is a condition where patients can have overlap of symptoms between microscopic polyangiitis and granulomatous polyangiitis, where the patients will have extensive microvascular inflammation leading to a widespread disease. Now that we have understood primary vasculitis, let's look at secondary vasculitis. The important ones among these are drug-induced vasculitis, serum sickness, vasculitis associated with infections, malignancies, and rheumatic diseases. Drug-induced vasculitis is an important cause of secondary vasculitis, and the following are the drugs that are implicated in this drug-induced vasculitis. Antibiotics, including penicillins, cephalosporins, macrolides, minocycline, quinolones, sulfa antibiotics, clindamycin, and nitrofurantoin. Anti-thyroid drugs are also implicated in drug-induced vasculitis. Anti-epileptic drugs including carbamazepine, lamotrigine, phenytoin, phenobarbital. Antihypertensives including hydralazine, methyl dopa, NSAIDs, that is ibuprofen and naproxen. Immunomodulating agents including TNF alpha inhibitors such as infliximab, adalimumab, golimumab. Immune checkpoint inhibitors, granulocyte colony stimulating factor agonists such as filgrastim. Filgrastim is particularly associated with aortitis. Interleukin 6 inhibitors such as sarilumab and tocilizumab. JAK2 inhibitors and other JAK inhibitors such as tofacitinib. Anti-rheumatic drugs including D-penicillamine, methotrexate, and sulfasalazine. Anti-cancer drugs are also implicated in drug-induced vasculitis, and warfarin is also implicated in drug-induced vasculitis. Other medications include psychoactive drugs such as cocaine. Let's look at the evaluation of vasculitis. The evaluation involves a thorough history and physical examination with special attention towards ischemic manifestations and systemic inflammatory signs. Laboratory investigations include measurement of erythrocyte sedimentation rate and C-reactive protein. In vasculitis, erythrocyte sedimentation rate is generally in the range of 50 to 100 millimeter per hour, and even C-reactive protein is raised. Other tests include complete blood count, a urine analysis with special attention to proteinuria, which can be a marker of early kidney involvement. Renal function tests, liver function tests are also performed. Antinuclear antibody tests, rheumatoid factor test, anti-glomerular basement membrane antibody test, screening for HIV, hepatitis B virus and hepatitis C virus infections, and screening for underlying malignancies need to be performed. In evaluation of vasculitis, an important anti-neutrophilic cytoplasmic antibody or ANCA is utilized to diagnose vasculitis. There are two important types of ANCAs, that is C ANCA, which is proteinase 3 ANCA, or also known as PR3 ANCA. The other is P ANCA, or also known as myeloperoxidase or MPO ANCA. These ANCAs in various proportions are associated with granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. It must be understood that ANCA is a adjunct test and should not be used alone in diagnosis of vasculitis. In diagnosis of vasculitis, biopsy of affected arteries play a vital role, where there is lymphocytic infiltration of the blood vessel wall. Chest X-ray can also be used to look for pulmonary involvement. So in a patient presenting with suspected vasculitis, clinical features and lab findings can help in diagnosis. If required, biopsy of the affected artery or arteriogram can also be utilized to come to a diagnosis. And once the diagnosis of vasculitis is established, it is important to categorize to a particular vasculitis syndrome. Examples include Wegner's granulomatosis or granulomatosis with polyangiitis, or eosinophilic granulomatosis with polyangiitis, or microscopic polyangiitis, or polyarteritis nodosa, or Takayasu arteritis. And these patients are further treated according to the guiding regimens. In parallel, patients should also be screened for offending antigens. In such patients, if there is an antigen which is present, then the removal of the offending antigen needs to be done. If there is no antigen that is present, then treat it as vasculitis. In case of a removal of offending antigen, patient should be followed up for resolution of symptoms and if there is no resolution, then patient can again be subjected to treatment for vasculitis. In parallel, again, patient needs to be screened for underlying disease, which basically establishes a secondary vasculitis diagnosis. In such patients, HIV or hepatitis B or hepatitis C virus malignancies or drugs need to be ruled out, and these patients can be treated with removal of offending pathogenic molecule or treating the infection. In evaluating for vasculitis, it is important to understand the differential diagnosis, and these differentials usually mimic the features of vasculitis. These include infectious diseases, coagulopathy, neoplasms, drug toxicities, and other conditions. Infectious diseases include bacterial endocarditis, syphilis, coccidiomycosis, histoplasmosis, particularly pulmonary histoplasmosis, Rocky Mountain spotted fever, Lyme's disease, and even Whipple's disease. Coagulopathies and angiopathies include thrombotic thrombocytopenic purpura, HUS syndrome, hemolytic uremic syndrome, antiphospholipid syndrome. Neoplasms include atrial myxomas, lymphomas, and carcinomatosis. Drug toxicities include cocaine toxicity, levamisole, amphetamine, arsenic, methyl sergide, and ergot alkaloids. Other conditions include sarcoidosis, atherosclerotic cardiovascular disease, amyloidosis, migraine, fibromuscular dysplasia, segmental arterial mediolysis, reversible cerebral vasoconstrictive syndrome, good pasture syndrome, that is anti-glomerular basement membrane disease, anti-GBM disease. Let's now look at the treatment of vasculitis. The treatment is based on specific vasculitis syndrome along with the severity of symptoms. As a general rule, immunosuppressive therapy should be avoided wherever there is no irreversible damage. Examples of such conditions include isolated cutaneous vasculitis. In treating the underlying conditions, antiviral play an important role, especially in hepatitis B and hepatitis C viral infections. In conditions requiring acute therapy, where the patient can have either life-threatening or organ-threatening disease activity, such as transient vision loss in a patients with giant cell arteritis or rapidly progressive glomerulonephritis. In such cases, immunosuppressive medications along with high dose glucocorticoids can be used. Some of the important medications used include prednisolone in the dosing of 1 milligram per kg per day, started initially, and it can be tapered according to the response from disease activity. Cyclophosphamide, usually given in the dosing of 2 milligram per kg per day and adjusted to avoid severe leukopenia. Patients taking cyclophosphamide are at a very high risk of bladder toxicity, and hence these patients should be advised to intake large amounts of water, especially in the morning. IV cyclophosphamide is given in the dosing of 15 milligram per kg every 2 weeks once for 3 doses, and following that every 3 weeks until symptom resolution. This regimen is associated with good suppression, but there is a high chance of relapse. In treatment with cyclophosphamide, treatment should be given to a maximum of 3 to 6 months, along with transition to oral methotrexate therapy. Rituximab, which is an anti-CD20 antibody, monoclonal antibody, is used in vasculitis in the dosing of 375 milligrams per meter square of body surface area as a IV infusion, weekly dosing. This is particularly useful in induction of remission in cases of granulomatosis with polyangiitis or microscopic polyangiitis. It can also be used every 6 months for maintenance of remission. In patients who cannot tolerate cyclophosphamide, or patients who do not have life-threatening or organ-threatening involvement in granulomatous polyangiitis or microscopic polyangiitis, such patients can be tried with methotrexate up to a maximum dosing of 25 milligrams per week. Methotrexate can also be used in maintenance of remission, especially after cyclophosphamide dosing. However, methotrexate cannot be used in patients with renal insufficiency or chronic liver disease. The other options include azathioprine, which is used in the dosing of 2 milligram per kg per day, is effective in maintenance of remission. However, it is not so effective in induction of remission or in treating active disease. Mycophenolate mofetil is also used up to a maximum dose of 1000 milligrams twice daily. This is particularly kept as a second line drug, especially after treatment failure with either methotrexate or azathioprine, and this is also not an effective medication for active conditions or active disease or in induction of remission in such patients. Tocilizumab, which is a anti-interleukin 6 antibody, monoclonal antibody, given in the dosing of 162 milligrams per week via subcutaneous route, when combined with glucocorticoids, has been shown to be very effective in treating giant cell arteritis and maintenance of remission in such patients. Mepolizumab, which is an interleukin 5 monoclonal antibody is used in the dosing of 300 milligrams given subcutaneously once a month, has been shown to be effective in treating non-life-threatening eosinophilic granulomatosis with polyangiitis.